Okay, so I am going to start recording, but what I wanted to show you guys was, oh no, do I not have it pulled up? Sorry. So after I took boards, I actually like wrote up like my immediate thoughts after boards, and I just wanted to show you guys on after I took STEP, one of the immediate things that I said were vitamins were absolutely super, super important on especially STEP. Huge. So just wanted to put that, it was like the only thing I highlighted on this entire document was literally vitamins. So these are very important. They're very, very clinically relevant. So I just wanted to preface that before we did vitamins today. And I will send that to you guys next year when you guys are prepping for boards. Okay, so we're gonna do vitamins, obviously, but then kind of like how I wanted to structure biochem, because I'm sure at this point you guys have done biochem, you've like gone to tutoring sessions on biochem. So what I thought would be really helpful was to just give you guys like clinical biochem questions, and then we can kind of do like a little tutoring after, like a mini tutoring session after it, if that makes sense. Because again, it's like you can memorize the pathways all you want, but what's going to be really important is like understanding how the pathways like apply clinically. So that's kind of like how I structured the biochem, and I took like the biggest concepts. But vitamins are very important. So I did want to start with vitamins. Here is my little tips for vitamins, because again, they're very, just like you saw on the first page, they're very important for boards. So there's going to be a lot of questions on them. So there is an Anki deck for vitamins. I know your exam's like coming up, so it's very long. So probably don't have time to do all of it, but maybe just like skim through it and just kind of like see what they deem to be important. Again, the reason vitamins are so important because so many of them tie into biochem. So that's kind of, again, boards attack biochem. They love biochem. They know people hate it. Learn the names. This is something that I think people forget. Like a lot of the times it's not going to be like, oh, it's vitamin B12. Like they're going to say cobalamin. And you're like, what is that? Like I've never heard of that. So learn the name. So like know the vitamin, know the name. And then this is kind of what I'm focusing more on today rather than like the actual like biochem portion of vitamins, because like you'll get that when you're doing your biochem, right? Whether you did like, Dr. Turco, or whether you did Boards and Beyond or whatever you use for biochem, they'll be like, oh yeah, B5 plays a role here. What I'm gonna more so do here, how relevant are the non-B vitamins? They're relevant. They are relevant. Those are not as important for biochem, but they are important. They're gonna come up a lot, and we'll talk about them. But that's a great question because that's kind of how I split this up, was like your non-B vitamins and then your B vitamins. Um, Okay, so a lot of what I'm gonna do is like vignettes. So like what you're gonna see, like a classic vignette, how do deficiencies present and how do like excess, like toxicities present. Like for example, B12, how does that present? How does A deficiency present? Whatever. If you have Boards and Beyond, there's like I said this is like from like an early, like if this was earlier, like if you used something else for vitamins, that's fine. But I do think the Boards and Beyond quizzes were pretty good in terms of like the clinical. B9 and B12 are definitely the most important. They're going to come up in like every single block from like here on out. They're super important. There is a lot for vitamins. That's why I'm going to try and go through them, not super quickly, but I really didn't go into that biochem because Turco, Boards and Beyond, whatever you use for biochem is good at kind of tying in those connections. I still put it in there when it was relevant, but you'll see I tried to make it a little bit more clinical and like a little bit more like, oh, this is kind of how they're going to ask about this in like a vignette. Okay, so we did talk about this iron fist bro thing. This is just like a need to know type of thing. Hopefully you remember this from anatomy. But iron fist bro, remember this is like where iron, folate, and B12 are absorbed in the small intestine. So iron is absorbed in the first part of the small intestine, which is the duodenum. Folate or vitamin B9, so see, start doing that. Start like being like, okay, so vitamin B9, this is reabsorbed in the jejunum, the second part of the small intestine, and then B12 or cobalamin is reabsorbed in the ileum. Okay. And another thing to kind of remember, and I kind of harp on it a little bit later, but remember B12 is reabsorbed in the ileum. That's also where those bile salts are reabsorbed. And remember when bile salts, yeah, and remember with Crohn's disease, where does it? They don't have it over here, but usually in Crohn's disease, the ileum is always affected. So a lot of the times Crohn's patients will present with like a vitamin B12 deficiency or like gallstones or something because they're not able to reabsorb bile salts. They're not able to reabsorb vitamin B12, but we'll go into that. The other thing to kind of know about vitamins is they can kind of be broadly classified into fat soluble versus water soluble. And fat soluble usually, typically, what that means is like it can be stored in like fatty locations, for example, the liver. So your fat soluble vitamins can be stored. So generally, and there's always exceptions to rules, but generally, the fat soluble vitamins tend to stay in your body a little bit longer. So it's a little bit harder to have deficiencies. So you do need to know what the fat-soluble vitamins are. It's vitamin A, D, E, and K. However you want to memorize that. It's just like one of those like need-to-know things. So A, D, E, and K. And then your water-soluble vitamins are your B vitamins as well as vitamin C. Now, an exception is vitamin B12 does get stored. It does get stored. It gets stored in the liver. We'll talk about it when we go into B12. But basically what this means, again, water-soluble versus fat-soluble, is if you are deficient in one of the B vitamins or vitamin C, there's no storage of them. Like the body can't just like go to the liver and be like, here, I'm gonna get vitamin C from the liver. It can't do that. So they'll present with like deficiencies a lot quicker than A, D, E, and K. Okay. So then here are those. We talked about it. Again, anytime you see the vitamin like letter and number, like know what the actual name of it is. It'll just be completely interchangeable. Okay. All right. So we're going to start with the fat-soluble vitamin. So again, this is A, D, E, and K. And basically, fat-soluble vitamins, these will form micelles in the jejunum. I will go into a little bit, I don't remember where I put it in here, but I will go into a little bit about lipid metabolism. But you'll see, like when you basically create a chylomicron, like when chylomicrons are being created, that's kind of where these fat-soluble vitamins are getting packaged. And remember, micelles, these are just going to be, a micelle is just a general term. That means that there's a hydrophilic head, so it loves water, and then a hydrophobic tail, so it hates water. So they make these little balls, and then the hydrophilic heads are on the outside, and then the tails all kind of go in the center like that. So the fat-soluble vitamins would be like in here, inside this little sphere micelle. Okay, and this is kind of how the body's able to transport lipids, which again are super fat soluble. They would hate the blood because there's so much water in the blood. This is basically how they get packaged and like move around the body in micelles. And again, we'll go into this a little bit more, but enterocytes, so like on the small intestine, they will absorb these fat-soluble vitamins, package them into nice little chylomicrons, secrete them in lymph fluid, and then they basically get carried to the liver, and then the liver can process them. But again, we'll go into a little bit more detail with that. Okay, so the first one is vitamin A. I tried to give a visual aid for all of them, so you can kind of like, I don't know, for my visual people out there, you can be like, oh yeah, vitamin A, I see a lot of orange. Carrots, you know, like everyone says, like have carrots, it's good for vitamin A. The other name for it is retinol. And if you notice the first, what is this, prefix? It's not really a prefix, but whatever. The retinol, this is a vitamin that's very important for visual pigments. And what makes up your visual pigments is the rods and cones within the retina. So it's kind of like, you can remember it that way. It's very, very good for sight. Dietary sources of vitamin A. So again, all of these vegetables, fruits, whatever, what have you, over here are very high in vitamin A. But what's really high in vitamin A is liver. Like literally like a liver of an animal. And I put this here and I put it in red and highlighted it because we had a question on our exam about this, or boards, I can't remember. It's a lot of vitamin questions on something. But they asked a question and it was basically like there was this Eskimo and he was out in the like wherever, like out in Alaska, and he ate polar bear liver and died. And it was like, what vitamin, or like it tied it in somehow, and you're like, oh, that's vitamin A excess because liver has tons of vitamin A in it. You mean visual pigment as in the color you see or the color of your eye? Good question. Sorry about that. It's like, so, and I didn't go into too much detail because you'll go into sight when you get to neuro, like you'll go into this in a lot more detail. Your rods and cones are what allow you to see, just like anything, just allow you to see. These are just called visual pigments. Like these are like your visual pigment cells are rods and cones. So vitamin A, these rods and cones need vitamin A. And then if you're vitamin A deficient, which we'll go into, you can't see. Okay, so it's kind of like these visual cells to see require vitamin A to work, if that makes sense. It has nothing to do with like the color of your eye. Cool. Okay. And then, yeah, so then again, just kind of think of this picture. So dark green, yellow vegetables. A lot of these are going to be found in vegetables. That's why people say eat vegetables, they're good. But many people underconsume it, which again is not a terrible thing because again, it's fat soluble. It's going to get stored. So for example, like it's stored in the liver, it takes years. And this is going to be a common thing you see with the fat soluble vitamins. When it does get stored, remember these guys from histo? These are the cells that are storing it, the stellate cells or the ETO cells, which are in the liver. So remember this slide here? So here along the little biocanaliculi things within the liver hepatocytes, we have these stellate cells. Another name for stellate cells are ETO cells, ITO. So just again, it's like one of those interchangeable things. You could see it either way. When they're not active, they're just storing vitamin A. And another name for this is like the quiescent function of stellate cells. Quiescent meaning like they're not actively working. They're just kind of like they're not active. They're not doing like what their functional thing is to do. So when they're quiet, when they're inactive, no, they just store vitamin A. That's just what they do. When they become active, they will secrete extracellular matrix. And we did talk about, if you're like, I don't remember this at all, it's in those slides from the anatomy, wherever I talked about it. These are also going to be cells responsible for causing like cirrhosis because when they secrete this extracellular matrix, it causes fibrosis. So again, this is going to be kind of what helps, well, not helps, but what causes cirrhosis of the liver happening. Because remember, cirrhosis is just fibrosis and then the liver can't work properly. Okay, so stellate cells, these store vitamin A. That's just like a fun fact, need to know kind of thing. So deficiency. So again, because vitamin A is required for vision, basically, you're going to see visual symptoms. The most common one and often the first sign that you have a deficiency is called night blindness. So night blindness, I thought this was a really good picture to kind of explain what it is. It's like you're not blind, you're only blind when it's like dusk out. Okay, so when it's like the sun's setting, I just think this is a perfect way to describe night blindness. It just looks a lot, and it's not totally black either, right? It's not totally black on this side. It's just, it looks a lot darker than it probably should. That's night blindness. Another feature is called xerophthalmia. And basically what xerophthalmia is when the cornea, so if this is the eye, here's your pupil, and then the cornea are going to be on like outside of the pupil over here. The cornea are going to get these things called, I don't know how to pronounce it, bitot, I have no idea, bitot spots. And basically what it is, it's like this little spot like this, and it looks like rough. It looks like a little patch of like rough skin on your eye. It's gross. But it looks like that. It's called keratinization. And you don't have to know this right now because you'll go into it second year for hem-onc. Vitamin A is actually a treatment for a cancer because it allows for proper development of cells. But it does have to do with that. It has to do with that development process. So without vitamin A, it's like the skin for the eye doesn't develop properly and you get keratinization. Okay, so these are just symptoms. I'm pretty sure night blindness is going to be the one. If they were to ask you one, they'll talk about this, but just know you can have like, it's just going to be something with the eyes. Another thing that you can see is issues with the skin. Like I just said, it's because it allows for the development of like proper like keratinization is another thing that vitamin A does. But if you have a deficiency, you can get thick, dry skin. So imagine these bitit spots. I don't know if I'm saying that right. The bitit spots, but now on the skin. So you get these little patches of dry skin. They will try to trick you. They'll do it. So we're going to talk about vitamin B3, niacin. Vitamin B3 deficiency also presents with like a dermatitis is what they say. So don't get got, okay? Don't get got with that. Like just read the whole thing. They're still gonna give you like a visual symptom with vitamin A deficiency, okay? But just know that you can also see thick skin. So as soon as you see like thick skin, just don't be like, oh, this is B3, like this is B3 deficiency, okay? And again, because vitamin A is really important for growth and development of normal like cellular processes, you can also see growth failure in children. But I guarantee you they'll give you something visual with vitamin A. All right. So moving on to the next fat-soluble vitamin, vitamin D. So I didn't go into too much detail with vitamin D because you're going to go into this so much with endo when you get to endo next block because this is huge for like just it's technically like it's very important for like normal endocrine function in the body. But I did want to go into a little bit. I believe they did ask a question about vitamin D on our exam. Again, I forget which year, but I think this was still like a GI concept. So I just very briefly, there's two forms of vitamin D. One is called vitamin D2 and one is called vitamin D3. Vitamin D2, this is called ergocalciferol. So again, just trying to have you see both names. This is found in plants, fungi, and yeast. Vitamin D2 is the inactive form of vitamin D. It's inactive. Vitamin D3, this is called cholecalciferol. This is the active form of vitamin D. So basically how you can get vitamin D3 is you can eat fish, have milk, certain plants have like the active form of vitamin D. Or as soon as you go outside, that's why people say like, oh, if you go outside, like get some vitamin D, right? Like if I'm out in the sun, I'm getting some vitamin D. It's because just UV light being exposed to the skin can actually it can synthesize vitamin D3, which is really cool. Okay, so that's the difference between those two. So basically, where can you get vitamin D3? Diet and sunlight. Okay, and kind of like, again, this is what you're going to go into a little bit more in endo, but I just kind of wanted you to see this process because it's kind of confusing because foods do have D3, but then you can also have D2 and then that can get converted to D3. So if you, like, let's say you have vitamin D2, either D2 or D3 can get converted to what's known as 25-OH-D3. And again, I'm sorry, this is where it gets in. You do have to know that 25-OH-D3, this is the storage form of vitamin D. It's called calcidiol. And I remembered, well, we won't go into it, but calcidiol is the 25-OH-D3 storage form. Then it gets converted, so that's happening in the liver. And then down in the kidney, it gets converted to 125-OH-D3, which is called calcitriol. So we have diol and triol. And then this is the active form. So basically what I'm trying to say is you need both a healthy liver and a healthy kidney to make the active form of vitamin D, okay? You'll go into this a lot more in endo. If you're like, this makes absolutely no sense to me, you'll go into it. I just wanted you to see all the names of vitamin D. Another kind of trick in vignettes is like they'll talk about like how infants are exclusively breastfed. Like if you have an infant that only has breast milk, no other supplements, you need to give them vitamin D supplementation. Breast milk does not have vitamin D in it, and vitamin D is also really important for like normal growth. But what does vitamin D do? Just very, very generally, think of vitamin D causing intestinal reabsorption of calcium and phosphate. And this is where it says like milk builds strong bones. It does. It really helps to, and again, you'll go into this in endo, how specifically it's causing the strengthening of bones. But it has to do with calcium and phosphate. But let's say you have hypervitaminosis D. So you have too much vitamin D. You'll see symptoms of hypercalcemia and hyperphosphatemia. Again, you'll cover this in endo. Like, what does this look like exactly? And then the same is true for hypovitaminosis D. You'll see symptoms of hypocalcemia and hypophosphatemia. And just kind of briefly, because again, the deficiencies are very clinically relevant. If you don't have vitamin D, you're not going to absorb calcium and phosphate properly. And this is kind of what we talked about. Here are some symptoms of what hypocalcemia is. Usually it's like you have seizures, you have convulsions, you can have heart arrhythmias, you can have tetany, so like just spasms and like stiffening of your muscles, certain things like that. And in the bone, obviously, you need vitamin D to build strong bones. So you get poor mineralization of bone. This will make sense again when you do endo. And you can get osteomalacia in adults and rickets in children. They're the same disease. It's basically like poor mineralization in adults is called osteomalacia, and poor mineralization in children is called rickets. Okay? But typically it's like, oh, if you have a child with a vitamin D deficiency, usually what they'll say in the vignette is you have this child that like just stays inside all day, never goes outside ever, and like kind of abused. So like there's not a healthy diet there. And it's like now it's like they have all these bone issues. Like their bones are very weak and it's like, oh, that's a vitamin D. That's rickets. Okay. I thought calcium and phosphate were reciprocally related. Yeah, you'll go into this a lot more. This is because of parathyroid hormone specifically, which again is a hormone. I didn't want to go into it. So you probably learned it with kidney, with renal stuff. Yeah, you'll go into it. I promise. I'm not leaving anything out that I think you guys need to know. I just don't want to overwhelm you with like endo stuff yet, because you'll be like masters of this next block. Okay, but yeah, calcium and phosphate. Technically, yes, are reciprocally related, but when parathyroid hormone gets involved, it gets a little different. And vitamin D is regulated by parathyroid hormone. Well, it can be. Okay, cool. All right, so next is vitamin E. So your next storage, like your fat-soluble vitamin. The other name for it is tocopherol. There's not much to say about this, honestly. It's an antioxidant. I'm sure like when you were doing biochem with whatever source you're using for biochem, they talked about what antioxidants do. But just very briefly, if I had to describe what an antioxidant does, I would say it protects the red blood cell and like cell membranes in general from free radical damage. So there's a bunch of stuff in the body that they're called free radicals. They can come from oxygen, they can come from all sorts of different places. Antioxidants kind of like sweep those up. They kind of like neutralize those free radicals. So antioxidants are really good. People are like, oh, have blueberries, tons of antioxidants, right? They're basically saying there's tons of vitamin E in that. Basically, that's the entire point of what vitamin E does. It's really hard to become deficient because, again, it gets stored. But if you were to have a vitamin E deficiency, which again, I really have never seen a vignette on vitamin E deficiency, but it would present with basically like not being able to protect your red blood cell and your regular membranes from damage. So you'll see something like hemolytic anemia, which is a type of like red blood cell issue where your red blood cells just get bursted open because there's nothing protecting the membrane. You can also see neurological symptoms because again, like there's cell membranes. I mean, you can see damage everywhere. But typically, if you have vitamin E deficiency, it's like neurological symptoms as well as like some sort of like red blood cell issue where they're just like lysing open. That's all I have to say about vitamin E. All right, vitamin K is your last fat-soluble vitamin. You will really love vitamin K when you get to hem-onc because this is basically the vitamin that activates clotting factors. Clotting is what basically stops you from bleeding. So think of vitamin K as being the same as causing you to stop bleeding. Okay, so I'm saying this in advance so you can be like, oh, deficiency is probably bleeding. Yes, exactly. So, but vitamin K in the meantime is what basically stimulates these clotting factors in the body. And the ones that are vitamin K deficient, and there's 12 clotting factors, I forget. I think there's 12. I think there's a little bit more, but the ones that are vitamin K deficient are dependent are 2, 7, 9, and 10. So factor 2, factor 7, factor 9, and factor 10, they all require vitamin K to work. And again, we don't worry about that yet. If anything, just kind of memorize like, oh yes, vitamin K, clotting, deficiency, bleeding. Vitamin K is found in green leafy vegetables. Honestly, all of these are. Don't like memorize the specific food like all of these are going to be in vegetables, right? There are specific ones which I'll be like, oh, you should know like this is where you get this source. Like vitamin C, for example, you should know that. Something interesting is that vitamin K is synthesized by GI bacteria. So your normal gut bacteria are just making vitamin K, which again, it's really hard to become vitamin K deficient if you have normal GI bacteria. They're just making it all the time. So deficiency is bleeding. Like I said, dietary deficiency is very, very rare because we have GI bacteria. So think about some things that would cause a deficiency. One, antibiotic use. I don't know how much you guys know about antibiotics, but antibiotics, especially if it's what's known as a broad spectrum antibiotic, means it just like, it doesn't care. It'll take any microbe that's in your body, any bacteria that's in your body, it'll just take it out. They'll kill your good bacteria, like your gut bacteria. So if you're like on antibiotics for a very long time, you could have a vitamin K deficiency potentially. Another thing that's interesting, and this is clinically relevant, my friends have like done this on their peds rotations, is all newborn babies get a vitamin K shot. So because newborn babies, they don't have their own gut bacteria yet. They haven't developed it yet. The only things that newborn babies have is everything from mom, like some antibodies from mom, but they don't have their own GI, like flora, for example. They don't have that yet. So that's why automatically baby's born, boom, gets a vitamin K shot. Okay, and it's just an injection and then they're good because it gets stored and they're good. And then you don't have to worry about this because it's hem-onc, but I just wanted you to know like some blood thinners, so an example is warfarin, it physically causes vitamin K deficiency. Like that's the whole point of this blood thinner is to cause a vitamin K deficiency so you don't clot. And there you go, it's an anticoagulant. So that's like my little plug there. So it's kind of cool to know that. It's like, oh, this is very relevant because now you can use pharm to kind of play off of vitamin K. All right. So those are your fat-soluble vitamins. Next, I'm going to go into vitamin C, which is an example of a water-soluble vitamin, but it's not a B vitamin, but it's still water-soluble. So this is the only water-soluble non-B vitamin. This is found in fruits and vegetables. Specifically, it's found in like citrus. So lots of citrus foods like tomatoes, limes, lemons, and lots of sources, but specifically like your citrusy fruits. There's three key roles. Like I said, you will go into a lot of these a lot more in second year. Specifically, Pathoma, which is like what you guys use second year, he goes into vitamin C a lot and is like, here's every place. So you don't have to know this in that much depth right now, but just like keeping you aware of these are things that vitamin C actively does is it helps you absorb iron. It helps you synthesize collagen, and it helps you synthesize dopamine, which is a neurotransmitter. So deficiency is going to be issues with those three processes. So the first one is the deficiency of vitamin C causes scurvy. And all scurvy is it's defective collagen synthesis. So everywhere where there's collagen in the body is not going to be able to like be normal, for example. So there's lots of collagen in like the gums. Your blood vessels have tons of collagen. There's collagen everywhere. There's different types of collagen. Even your bones have collagen. There's collagen everywhere. But specifically, like what's most affected with scurvy is you start losing your teeth, your gums get sore, your blood vessels get really fragile. So you get sore gums, lose teeth, easy bruising. And the whole point of scurvy is that this was like historically, this would be pirates would get this. So pirates would get scurvy just being on long voyages because again it's a water soluble vitamin, it gets washed out super quickly. So what they would do is they would eat limes on their boats on their sea voyages. Yeah, like they would eat limes to prevent scurvy. And that's why like if you ever see like old pictures of pirates, they'll be like sucking on a lime, and that's why it's like to prevent scurvy. But we are not treating pirates, and the boards know likely you will not see a pirate as your patient. So how they kind of get around this is like your patient population for scurvy, especially on boards and in vignettes, is going to be like your elderly old woman who basically just has tea and toast. So they say like, oh, this is commonly seen with a tea and toast diet, which means like, oh, they're only having toast and they're only having tea. That's all they want to eat. They don't really want to have fruits and vegetables. So again, that's like your patient population is an elderly old woman that like barely eats anything is gonna might present with scurvy. Okay. All right. So then your B vitamins. These are all gonna be water soluble. Vitamin B12 is the only exception, but we'll talk about it. All right. So here's my tips for your B vitamins. Again, all water soluble. Again, your exception is B12. Huge ties to biochem. And again, I went into biochem a little bit here, but I know you guys are getting it with biochem, and we'll go into it a little bit more at the end. But just at least know which ones are cofactors for which reactions. They will talk about like, oh, if you have this vitamin deficiency, which process here in the body can't happen? Like, can you make fatty acids? Can you make, I don't even know. Can you make can you go through gluconeogenesis? Like which ones are cofactors for which reactions? Which enzymes require these B vitamins? And something I want you to also keep in mind is commonly for all vitamin B deficiencies, you're going to see these things. So you're going to see dermatitis. This is a skin issue. You're going to see glossitis, which is going to be basically swelling and redness of the tongue. You'll see diarrhea, which is a GI tract issue, and you'll see cheilitis. And cheilitis is basically like when you have cracking at the corners of your lips, like when the very corners of your lips get like little cracks in them, that's cheilitis. So when you're going through these like vitamin B deficiencies, you're going to see a lot of them overlap, and that's okay. Don't focus on that too much. I'll kind of point out like, oh, this is kind of like the main differentiating feature of this B vitamin versus another one. But again, the reason why you see like all these areas require a lot of energy. They have high cell turnover. Your skin, your GI tract, like they're constantly turning over, making new cells and stuff. You need biochem. You need energy to do that. So if you can't have these enzymes working for these biochemical processes, you're not going to be able to turn over these cells rapidly. Okay, so that's kind of why you see these symptoms with these B vitamin deficiencies. All right, so your first one is thiamine, so vitamin B1. Oh, and I also highlighted in orange, at least the B vitamins I thought were like, just you should know every single thing about it. Okay, so this is one of them, vitamin B1, huge time. You'll probably talk about thiamine in every single block from here to boards. It's very important. So I did talk about which enzymes require this as a cofactor. It's the three, I don't know if you guys watched the Turco videos, but he kind of called them the tender love and care for Nancy enzymes, and it's what these 3 enzymes require these 5 things. No, 4 things. It requires thiamine, thiamine pyrophosphate, so vitamin B1, lipoic acid, um, coenzyme A, FADH2, and then NADH. So all 3 of these enzymes require these, it is 5 things. These 5 things. Oh, I didn't highlight the F. And then additionally, transketolase, which is a part of the H&P shunt, also requires thiamine. Okay, so pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, which is a part of the TCA cycle, alpha keto acid dehydrogenase. The other name for this is the branched chain amino acids enzyme. This is the enzyme deficient in maple syrup urine disease. Also highlighted this because I believe that this was a question on my exam, and everyone was like, what the heck is that disease? It's like mentioned very briefly, so I just wanted to point that out there. But these are all of your tender loving care for Nancy enzymes, so they all require thiamine. And then transketolase is not a tender loving care for Nancy enzyme, but it does require thiamine. And this is involved in the H&P shunt. Okay, so thiamine, what does it do? So that's basically what thiamine does in the body. It's this cofactor for all sorts of different enzymes involved in all sorts of different things. And the deficiency for B1 is very clinically relevant. So there's 2 that are very, very important. So the first one's called beriberi, and then the second is called Wernicke's encephalopathy or Wernicke-Korsakoff. You might see it as like Wernicke-Korsakoff. So beriberi can be differentiated into wet and dry beriberi. So wet beriberi means that you're going to have I think of wet beriberi as the blood is involved, which I know that's probably the case for both of them, but that's just how I remember it because blood is wet, I guess. But you have tachycardia, the heart is involved. So tachycardia, you have high output heart failure, you have edema. It just seems like the blood's in, you know what I mean? You just seem swollen and wet, so to speak. You can also have dry beriberi, which presents with no cardiac symptoms. You have polyneuritis, so you just have neuropathy, tingling of just multiple nerves in the body. You can have muscle weakness. You have a lot of neurological symptoms, which again you'll go into in neuro. But that's wet versus dry beriberi. Both are vitamin B1 deficiency. For some reason, some people get wet, some people get dry. But regardless, whatever form of beriberi you have, it can progress to what's known as Wernicke-Korsakoff, and this is where it's really bad. So Wernicke-Korsakoff starts as what's known as Wernicke's encephalopathy. Wernicke, I think, is just the guy that came up with, I think it's just the guy that discovered it. Everyone wants to name themselves, they want to name a disease after themselves. Encephalopathy is basically how you would think encephalopathy would be. Encephalopathy is the brain becomes pathologic. And again, not going into too much detail because you'll cover it in neuro, but that's kind of what happens. And I'm going to jump down really quick, but the symptoms are all going to sound like neurological stuff. So you have confusion, you'd like to lie, you have ataxia, which means you have difficulty walking, you have difficulty maintaining your balance. That's a neurological thing. And you have blurry vision, just all sorts of stuff. You just seem out of it, basically. That's Wernicke's encephalopathy. Yes, so we'll talk about alcohol. Is lying confabulation? Yes, I'm sure you're talking about that Anki card, but yes, lying is confabulation. I think I have a slide on the exact triad for Wernicke-Korsakoff. But yes, another word for lying is confabulation, confusion, ataxia, blurry vision. Honestly, anything that seems like it's just affecting the brain. And the reason I put alcoholics here, and this is so I really wanted to kind of give you a little preface. So remember how I was talking about back with the acid base stuff for the renal portion of your exam, and I'm oh, this is what they're gonna say, and then when they say this, they want you to think this. This is another example when they say that there's an alcoholic in a prompt, especially in this exam, when they're oh, this patient's an alcoholic, they drink tons of alcohol, whatever, however they word it, but it's this person's an alcoholic. They already want you to think they are not eating food. Okay, so in your mind, you should be okay, alcoholic, not eating food. All right. So in this instance, if you have an alcoholic and they're not eating any food, of course your water-soluble vitamins are going to be the first to go. So thiamine deficiency is typically going to present in alcoholics. And a little clinical pearl, a little tie-in to clinics, is usually when unconscious people come into the ER. Back in the day, it was oh, give them some glucose. Maybe they're in a hypoglycemic coma, give them glucose. Now it's you cannot give them glucose. You must give them thiamine. You must. You have to give them a little shot of vitamin B1. And the reason why is because if you give them glucose, remember what enzyme requires thiamine, pyruvate dehydrogenase. You're not going to, and even this one, alpha ketoglutarate dehydrogenase, you're not going to be able to do anything with that glucose because these enzymes can't work. The patient's going to die from lactic acidosis. If you give them glucose and these enzymes can't work and can't do anything with the glucose, they'll just die of lactic acidosis. So now an unconscious person comes into the ER, they automatically get thiamine, automatically. And then once you give them thiamine, then you can kind of give them glucose, especially if you think it might be like a hypoglycemic coma or something like that. Does that make sense? I put like really important because this is like a classic like gotcha question, either in like on your rotations or on boards. It's like you have to give them thiamine before glucose. Oh, sorry, berries only transketolase Wernicke encephalopathy 10 11 care for Nancy. No. So berry is the definition of a vitamin B1 deficiency. Berry can then progress to Wernicke's encephalopathy. So it's kind of like when the berry like the deficiency becomes so bad that you become how do you say that? You get encephalopathy because of this deficiency. It got so bad. Does that make sense? Maybe I'm not understanding your question, but it's like it really doesn't have anything to do with the enzymes. It's just because you can't use any of these enzymes overall. It's going to cause like this mix of symptoms that's going to eventually lead to Wernicke's. Okay. So yes, good question. So when does it become Wernicke-Korsakoff? It can go to it. Oh, sorry. I thought it was a sugar that's made by transketolase that's causing the mental problems. So remember, transketolase is only involved in the H&P shunt, but like these guys are involved in glycolysis, in the TCA cycle, in this branched chain amino acid stuff. So it's kind of like it's the sugar that's everywhere in the body, like all these like the enzymes that are making sugar from glycolysis, well, using sugar for glycolysis for TCA through the H&P shunt, all of them require B1. And if they don't work overall, it's kind of like the body's like, oh, like we're going to switch to lactic acidosis. And then eventually you'll start getting these symptoms of your B1 deficiency. And that's berry. And then if you give them more sugar, they die because these enzymes don't work. I might just be being confused by your question. We can talk about it. We can talk about it after. But I would just know it's literally all of these. And then it can present with berry. And I have another graphic to show you, like, again, oh, here's berry. And then, oh, look, it progresses to Wernicke's. Maybe the graphics. Let's do the graphic. We'll do the graphics first. So Wernicke's encephalopathy is again going to be thiamine deficiency, chronic alcohol abuse. Here's your triad. So this was kind of like the question from earlier. You get confusion. You get broad-based, like ataxia, confusion. You get like weird stuff going on with your eyes. Here's your classic triad. And then eventually it will progress. So I don't know if it's like there's a specific time when it's like, oh, it's progressing from Wernicke's to Wernicke's encephalopathy to Wernicke-Korsakoff. But what is important to know is Wernicke's encephalopathy is reversible. You give them thiamine, you can reverse this. Once it turns into Korsakoff, you can't reverse it anymore. It's irreversible, and that's really bad. And again, I'm not going into too much detail with this because you will go into so much detail with Wernicke-Korsakoff when you get to neuro, but it's basically like this patient, they have memory loss because it affects, like, not having thiamine affects certain cells in the brain. So you literally have memory loss, and then the reason they lie or make these confabulations is because they like don't remember what happened. So they just are like, oh, like, they make up a story because they're like, they know something happened, but they don't remember. So they just make something up. And that's like a hallmark of Korsakoff. But again, that's going to be a neuro thing. You'll probably get questions on this in neuro because, again, there's a little bit more that goes into it. But I just wanted you to, see the main, kind of like the main symptom of having a B1 deficiency is this really bad disease, Wernicke-Korsakoff. That's irreversible. And this is kind of what I was mentioning earlier with the graphic. So here's berry. So thiamine deficiency in general is just called berry. And it can either be dry berry, which is like this first part, which again, very neurological. So you have like loss of reflexes, you have numbness, you have all these tingling. They call that polyneuropathy, wrist drop, like all sorts of various things. it can go directly to wet beriberi, or it can start as dry and go to wet. It's just kind of like person to person. But wet beriberi is, again, think of it like as high output, like heart failure, basically. So you have like these heart symptoms, you have this cardiomegaly, you have edema, so you have edema down here, you have like issues breathing, the orthopnea, so issues when you're laying on your back, you feel like you can't breathe. And then from here as well, it can progress to Wernicke's encephalopathy, which is basically like when you go through this progression of beriberi, here's Wernicke's encephalopathy. It can kind of kick in. So here's your ophthalmoplegia, which is just issues with the eyes, confusion, like I said, just neuro stuff. And then from here, if you still don't treat it at this point, that's when it can go to the Korsakoff syndrome, and that's completely irreversible. Does that make sense? It's a lot because, again, you guys haven't had neuro yet. And I always say this, I think everything makes sense after neuro. Everything really makes sense after neuro. You're like, oh my God, the whole body is like, makes sense. Okay, but I think this is enough for you guys to know for now. It's just understanding like what beriberi is, and that's a B1 deficiency, and it's because these enzymes can't work. And if these enzymes can't work, it's like, oh, we can't do anything in the body, and that's why you get like these really bad symptoms. Yes, exactly. So beriberi can lead to Wernicke's. Well, yes, beriberi can lead to Wernicke's, so like this, and then Wernicke's encephalopathy can lead to Wernicke-Korsakoff. Usually, a lot of the times you'll see, I didn't even put it on here, but you'll see it as like I'm not going to say it all out, Wernicke-Korsakoff syndrome. Like that's how it'll present, like Wernicke-Korsakoff, and that's like usually what you'll see when you're doing like questions. They'll say like, oh, this patient has Wernicke-Korsakoff. Wernicke's encephalopathy is like, it's not Wernicke-Korsakoff yet. It's kind of like you can still reverse it if they're only at that encephalopathy stage. Once they get to that Korsakoff syndrome, now it's called Wernicke-Korsakoff. Now that's completely irreversible. That's when they start lying because they can't remember what happened. And that's because like the actual cells in the brain are dead, like they died. And that's why it's irreversible, because you can't make more neurons. Okay, so Wernicke-Korsakoff is pretty much, if you're thinking like, oh, Korsakoff syndrome, this is basically the same as Wernicke-Korsakoff, because again, to get Korsakoff syndrome, you need Wernicke's encephalopathy. So that's why a lot of the times people just like like they just put the little dash. But yeah, it progresses, reversible, irreversible, and then beriberi. So there's all sorts of different things that can happen with B1 deficiency. You can start with dry and go to wet. You can start with wet. You can just present with Wernicke's encephalopathy, or maybe they're presenting with Wernicke-Korsakoff. Like maybe they're coming in and they're already presenting with Wernicke-Korsakoff. It just depends like where in this deficiency you kind of catch the patient. And a lot of the times, again, you'll see this in neuro. They'll talk about like a homeless person. They'll talk about like, oh, this was a homeless person that came in to the ER, and that's kind of why it's like you don't know how, like the last time they even saw a doctor or had a meal with vitamin B1 in it. Okay. All right. So that's B1. We love thiamine. But remember, patient comes into the ER and they're unconscious, thiamine, not glucose. All right. So next is vitamin B2. This is called riboflavin. So riboflavin is just generally, it's used in the electron transport chain. So it's just important to make energy. So again, it's all those symptoms we kind of talked about. So like we talked about dermatitis, glossitis, cheilitis. So issues with the skin. Issues with the corners of the mouth. Deficiency is super rare, and it's just because so many things have riboflavin in it. But the symptom that's going to kind of like be you're like, oh, that's different from other B vitamin deficiencies. It's called corneal vascularization. So remember the cornea, it's going to be, this is the eye, here's the pupil. Your cornea is here. This is your cornea. See how there's blood vessels in the cornea? Those shouldn't be there. There should be absolutely no blood vessels in the cornea. So they call this corneal vascularization because now there's blood vessels in the cornea. That's really weird. So it's leading to these ingrowth of new blood vessels. Okay, so that's kind of like the, I guess, like unique symptom to a B2 deficiency, but it's, again, super rare. All right, this is another important one. So vitamin B3, this is called niacin. So niacin is found in grains, milk, meat, liver, just lots of sources. But, and this is, I think it's funny that I have to like say like, oh, it's not found in corn. But the reason why I say like, oh, it's not found in corn, because the vignette will almost always mention like, oh, they're from this tribe that doesn't eat corn. Or sorry, it's from this tribe that only eats corn, or it's from this specific community in this country that only eats corn. There's a corn-based diet. And when you see that in a vignette, you should automatically be thinking, all right, this is gonna maybe be like a niacin question. Okay, so it's not in corn. So in people that only eat corn or corn-based products, think of the corn kid. Oh, I should have put the corn kid here, just little visual aid. Anyone that just exclusively eats corn, they might have a niacin deficiency. And people say the 4Ds, the 3Ds. I think it's 3Ds, but like my little group added the 4Ds because it does lead to death. But the classic 3Ds of niacin deficiency is dermatitis, diarrhea, and dementia. And you're like, wow, that's not helpful at all because that's everything that normal B vitamins are, that's what happens. But something that's interesting is the dermatitis is only in sun-exposed areas. So that's like one tip. So for example, this image here, I can tell this guy was wearing a tank top. So I can tell he was wearing a tank top, and you can see, all right, sorry, proving my point here. All right. So see how he has this dermatitis. So imagine he was wearing a tank top like this. Notice his stomach has no dermatitis at all. It's like the neck area, the arms, the hands especially. Anywhere that was exposed to the sun is going to have the dermatitis. So that's your first clue. And then the second clue is they're going to say something about corn. They're going to do it. They're going to say it because that's, again, the only kind of way to figure it out. Is this also heart-and-up disease? Great question. So heart-and-up technically is a tryptophan deficiency, but yes, it can lead to this. It can lead to similar to niacin deficiency. Yeah, I forgot about heart-and-up disease, but yeah, that's tryptophan specifically, but it leads to very similar symptoms. Okay, so your 3Ds, and then we say the fourth D because if you don't treat this, they can die. They can actually die from this. Okay. All right, vitamin B5. So vitamin B5, the other name for this is pantothenic acid. Tryptophan makes B3, right? Yes. Yes. You guys are knowing more biochem than me. Yes, but yes, tryptophan. So heart-and-up disease, it's an issue with reabsorbing tryptophan, right? So you can't, you basically don't have tryptophan in your body. And then if you don't have tryptophan, you can't make niacin. Boom, you get the nice little whatever this is, the niacin deficiency. There's really no name for it, but yes, you get like the exact same symptoms. But with that, they would probably talk about like a child. Like it would probably be something like that rather than like something nutritional, because with heart-and-up disease, that's genetic. It's like you're unable to reabsorb or make, I think it's reabsorbed tryptophan, but I could be wrong. It's been a minute. But it presents exactly the same. It's just going to be the patient population is going to be a little bit different. This is going to be probably like an older person that, again, they're going to mention corn. They're not going to mention corn with heart-and-up disease because that has nothing to do with corn. It's just they can't make niacin. Okay. All right, so vitamin B5, pantothenic acid. This is your essential component of coenzyme A. So I didn't put all the biochem on here because I just thought it was a lot and I didn't want to miss anything. But anywhere in the body where it's like you need coenzyme A, so even to make acetyl-CoA, you need vitamin B5. Vitamin B5, like the kind of the running, not joke, but the running theme of vitamin B5 is that it's just a cofactor in like everything. Like B5 is just a cofactor everywhere. So it's the same with B5 and B6, but I always thought of B5 as being the same as like anytime coenzyme A is involved, you need vitamin B5 or pantothenic acid. This is widely distributed in food, so again, deficiency is super rare. If you are to have symptoms, it's going to be all the same we kind of talked about. You're going to get like the diarrhea, the GI symptoms. You can still get like the dermatitis, glossitis, all that stuff. But the interesting thing for B5 deficiency, and this is going to be, I guess, like your unique feature for B5 specifically, is going to be, they call it like, it's paresthesias of like the feet, like the bottoms of the feet. So they'll say like, oh, the patient will say like, they feels like their feet are burning, which is that's like a very specific terminology. Because I know with like, when you have diabetes and people can't, like diabetic foot, right? Like they can't feel their feet because they have this like peripheral neuropathy, like the nerves are getting affected by the glucose. So it's like they can't feel their feet. This is like, usually it's very specific. It's like, oh, I feel like my feet are on fire. That's usually when they say that, they're trying to get at a vitamin B5 deficiency. But this is very rare, so they don't usually bring this up. I don't even remember if I've ever seen a question on this. Okay, but that's kind of how you would differentiate between the other B vitamins. All right, B6. So this one's also another important one. I put it in orange. The other name for this is pyridoxal phosphate. So vitamin B6, this is another one like B5. It's just used in like everything. It's like a cofactor everywhere in the body. So it's used to make various neurotransmitters. It's used to make cysteine, which we'll talk about. We'll talk about that a little bit with B9 and B12. But cysteine is an amino acid. So you do need amino acids to make proteins. So it's important for that process. And it's really important for heme synthesis. Like you can't make heme, which is a component of hemoglobin, which is, your red blood cells. It's the oxygen carrying component of red blood cells. So you can't basically carry oxygen with your red blood cells if you don't have hemoglobin. You can't have hemoglobin if you don't have heme. You can't make heme if you don't have vitamin B6. So that's why this is very, very, very clinically relevant. To have like B6 deficiencies, like it presents with a lot of like crazy stuff. The main thing it will present with is various like CNS symptoms, so central nervous system symptoms, so seizures, peripheral neuropathy, again, things where you can't make heme. Again, didn't go into it too much because heme-onc, it's literally an entire block dedicated to heme and like heme synthesis and stuff, so you'll cover it then, but just know it is very important for these processes. And classically, B6 is inhibited by a tuberculosis medication, isoniazid. And if you guys remember from the mnemonics for your metabolic acid, like your anion gap or non-anion gap metabolic acidosis, isoniazid, INH, was one of the like parts of that mnemonic. So I wanted to bring it back and be like, oh yeah, look, isoniazid is relevant again. Isoniazid inhibits B6. So classically, and I didn't bold this because I think this is more of like a second year thing, but it's just good if you're like doing a vignette and you see it, you're like, oh yeah, we did talk about that. If you give a patient isoniazid for their tuberculosis, you have to supplement with vitamin B6. That was a question I had on my Comlex actually. And they didn't describe isoniazid, they described the mechanism of action of isoniazid and then was like, oh, what do you have to supplement? I'm like, I already know this is B6. I don't even know if this is how isoniazid works, but I already know that's what you're getting at. Okay, and you can find B6 like everywhere. It's found in like, again, everything we've kind of been talking about is where you can find it. B7, so this is another one. It's kind of like thiamine in that you have to kind of know the enzymes that require it for biochem. So B7, biotin, this is a cofactor for carboxylase reactions. So anything that's going to has carboxylase in the name, basically. So pyruvate carboxylase, which is the one for gluconeogenesis, acetyl-CoA carboxylase, which is fatty acid synthesis, and propionyl-CoA carboxylase, which is involved with odd-chain fatty acid synthesis. So if you don't have biotin, you can't undergo these processes, and you can imagine that that's not good. That's not really sustainable with life. Deficiency is super rare. This is how they're gonna this is how they're gonna ask it if they were to ask about it, because it's really rare to become B7 deficient because it's just found everywhere. So what they'll say is, so massive consumption of raw egg whites can cause B7 deficiency. What happens is egg whites, so I know I should have put a picture of like an actual, egg white, not the yolk, but it's fine. So the egg white, like the not the yolk part, this part around it, contains a substance called avidin. And avidin loves to just bind up biotin. It just complexes with it. It loves it. It just binds to it. So then biotin can't be used in these reactions. But what they'll say because they know, everyone knows that raw egg whites have avidin in it. So what they're going to say is they're going to basically just say like, patient is a weightlifter and they eat 10 raw egg whites every day for 5 years. You need tons and tons of avidin to inactivate biotin. So it's got to be for a very long time. It's not like if you're sitting there and you're like, oh my God, I do this every day before I go to the gym. That's fine. This is like you do like you have like an abnormal amount of raw egg whites every day for a very long time. That's when you're going to get the B7 deficiency. Okay, and then the symptoms are going to be the normal symptoms because, again, now you're not allowing these processes to work in the body, and the body, especially the cells that are, like, requiring tons of energy, start breaking down. So dermatitis, glossitis, you have the GI symptoms, etc. Okay, but look for the raw egg whites. That's avidin. Sometimes they'll ask, like, what is the component in raw egg whites that inactivates biotin, and it's called avidin. So however they word it, just kind of keep that in mind, that avidin inactivates biotin, and then biotin can't be used, these enzymes can't work properly. Okay. All right, so vitamin B9 and B12, these are very important. These are going to be, you're going to cover these a lot moving forward. They're very important for DNA synthesis, meaning you cannot make new cells, for example, if you don't have B9 and B12. These are required to make new DNA. So B9, another name for it is the name for it is folate. You're going to cover this in hem-onc because certain chemotherapy medications try, they genuinely try to induce a folate deficiency. So then the cancer cells can't replicate because they can't make new DNA. So some cancer meds will do that. There's a certain antibiotic. It's called sulfamethoxazole. So it's like a UTI antibiotic. It literally targets bacterial folate because then the bacteria can't replicate if it doesn't have folate. So this, again, very clinically relevant to understand that B9 and B12 are very important for DNA replication. So cells can't replicate without it. B12, same thing. The other name for it is cobalamin. You'll cover this again in neuro, and because you get a specific neurological disease with vitamin B12. But I did want to go in, B12 deficiency, sorry. But I did want to go into this process here to kind of help you make sense with it because there is a biochem tie-in. So for example, here is kind of how B9 and B12 are involved with DNA synthesis. And then I'll talk about odd chain fatty acid metabolism over here. But with DNA synthesis, vitamin B9, so folate, it gets converted to dihydrofolate, which gets converted to tetrahydrofolate, and then it kind of goes through what's known as the folate cycle. This is clinically relevant, I promise. It's to how you can diagnose a B9, B12 deficiency. Then you get some methylation of tetrahydrofolate, and then eventually you can make thymidine, which is your T base, right? Like ATCG, I think are the bases. So thiamine, this is how you basically make thymidine, which is, again, used for DNA to base pair with adenosine. Then once that happens, you can get, it kind of just recycles and it goes through it over and over again, but it requires this enzyme called methionine synthase, and that requires vitamin B12. So B12 or cobalamin is a cofactor for methionine synthase in this reaction. From here, you can get methionine, this is your met, right? So this is always the first amino acid that's brought in when you're making new proteins. So again, very relevant. So here's methionine. It can get converted to S-adenosyl methionine. People abbreviate it as SAM, and I think of it as super awesome methylator, which is not at all the actual name of it, but it's very good at methylating things, so that's what I call it. And then it goes through a bunch of other stuff, and eventually you get homocysteine. And then from homocysteine, you make cysteine, which is just an amino acid, but it's a component of glutathione. And remember, glutathione, really important antioxidant. All right, so that's these cycles, and I promise these are relevant. I'll talk about why. But then over here with odd chain fatty acid metabolism, we have our odd chain fatty acid. It gets converted to propionyl-CoA, which gets converted to methylmalonyl-CoA. And then this enzyme called methylmalonyl-CoA mutase requires B12 to make succinyl-CoA. And then you guys know where succinyl-CoA, it basically gets shunted into the Krebs cycle. It can also be used for gluconeogenesis, going the opposite direction. So this is only vitamin B12. Methylmalonyl-CoA mutase doesn't need B9. So you can think of it as B12 is also important for this odd chain fatty acid metabolism versus DNA synthesis is B9 and B12. So I say all of this because, because let's say you have a B12 deficiency. So only a B12 deficiency. What's going to happen? This enzyme's not going to work. Cool. What happens if that enzyme doesn't work? Where did it go? We're going to have decreased levels of tetrahydrofolate. We're going to have oh my God. Okay. Sorry, I'm moving all over the place. Decreased levels of tetrahydrofolate, which means we're going to have decreased methylated tetrahydrofolate, which means we're going to have decreased thymidine, which means we're going to have decreased DNA synthesis. Just not going to happen. Also, at the same time, since this enzyme's not working, it's also not going to be able to convert homocysteine back to methionine, so it won't be able to go through this methionine cycle. So I'll have elevated homocysteine levels, and this is actually how you can, one of the ways to diagnose a B9 or B12 deficiency is look at homocysteine levels. So that's your first clinical tie-in. And then additionally, you can't use vitamin B12 the methylmalonyl-CoA has no cofactor, so it can't work. So you also have elevated levels of methylmalonyl-CoA, okay? But that's only with a B12 deficiency, only, okay? So I'm going to skip ahead actually really quick just to show you. So I'm going to skip because we're going to talk about this. So for folate and B12 deficiencies, homocysteine levels are going to be elevated in both because we were on that side of that dotted black line. However, methylmalonic acid will only be increased in your B12 deficiency because only methylmalonyl-CoA mutase requires B12. It doesn't require B9. Okay? So I wanted to show you the light at the end of the tunnel with biochem always. So that's kind of why if you mess up with B9 or B12 on this side with DNA synthesis, you're going to have elevated homocysteine levels. You're also going to have just decreased DNA synthesis no matter if this is deficient or, if this is deficient up here, it's going to present exactly the same. But conversely, if you have a B12 deficiency, you'll also have this additional elevation in methylmalonyl-CoA. So a lot of the times they'll throw that in there and be like, oh, is this a B9 or B12 deficiency? And methylmalonyl-CoA is elevated. You're like, okay, this is B12. Okay. But all right, so we're going to go into where you can get these guys. So B9 is folate, like I just said. It's used in the metabolism of homocysteine. It's absorbed in the jejunum. So this is iron fist, bro. So this is fist. It's found in green leafy vegetables. It's found in all of these things you see here. It's stored for about 4 months, which isn't that long. I know I said like, oh, it's not really stored. It gets washed out pretty quickly. This is still pretty quick. It does get washed out relatively quickly, but it's only stored for about 4 months. So think of, again, alcoholics as being deficient in folate. Again, a lot of the times when they mention alcoholic, they just want you to think they're not really eating or they're not eating what they should be eating because they're just drinking alcohol all day. Okay, so usually they'll mention it's an alcoholic and then it'll go into like the symptoms of like a B9 deficiency. B12 is also used in the metabolism of homocysteine, but additionally it's got that odd chain fatty acid synthesis as well. It's absorbed in the ileum, so this is iron fist bro, so B12 for bro. This is found in animal products. So I know people think like meat, but it's also like milk has B12, fish I guess is meat. Yeah, we'll do eggs, that's the other one. So eggs, milk, meat, it's basically everything that a vegan doesn't eat is what B12 is found in. So if you ever have a patient that's a vegan, you have to make sure that they're getting like B12 supplementation because everything that they don't eat is what contains vitamin B12. Okay, that's why it's not just meats, it's like animal products. And that's what vegans don't eat. They don't eat anything that like was made or comes from an animal. So it's stored for years in the liver. And this is almost like a fat-soluble vitamin because fat-soluble vitamins get stored for very, very long time. This is the only B vitamin that's technically stored. Yes, I just said folate gets stored for 4 months, but this is like years. So this is like, whoa, okay. So this is important. So when you're doing vignettes, when they talk about like, usually when they're trying to get you to think of like a B12 deficiency, they'll mention a vegan, but usually it's going to be at least a year. It can't just be like, oh, she became a vegan last week and now she's having these symptoms. Like it needs to be for at least a year. Various types of like various presentations for deficiency. So you can get pernicious anemia, which you probably will cover in Heme Onc. I will mention here, remember Crohn's disease, the ileum is always affected. So technically one of the treatments for Crohn's disease is to just remove the ileum. So then usually it's like I've seen vignettes where they'll like describe Crohn's disease and then it'll just go into B12 deficiency out of nowhere. And I'm like, oh, but that's what happened. You can just assume that they got their ileum out when that happens. Okay, so you can almost just assume. If they start talking about Crohn's and then like it sounds like B12, you're like, oh, they probably got their ileum out because they have Crohn's. And then the other one that can cause a B12 deficiency is, I hate saying this, Diphyllobothrium latum. This is a tapeworm that's found in raw fish. So usually in vignettes, how they'll word this is they'll say like, oh, a patient just had sushi or a patient just had raw fish, and now they're having these symptoms. That's usually this tapeworm. What happens is this tapeworm loves vitamin B12. So before it gets to the ileum, this tapeworm will just eat it. It's like, nope, that's mine. So it like sequesters the B12 and then none of it gets reabsorbed in the ileum. Okay. All right. So B12 deficiency only is going to have that high methylmalonic acid. And again, this is how they're going to differentiate between B9 and B12 deficiency. B9 deficiency has no elevated methylmalonic acid because B9 is not involved with methylmalonyl-CoA mutase. It has nothing to do with that enzyme. There's another thing, it's called subacute combined degeneration. This is a spinal cord, basically a spinal cord injury, but it's caused by B12 deficiency. I didn't want to go into what this was because it's like, you'll do it in neuro, but just kind of know that it's like, so like I have here, just know that with B12 deficiency, you get neurological symptoms too. You don't get neurological symptoms with B9 deficiency. So some examples of neurological symptoms are like numbness, like you get numbness, tingling, decreased proprioception, meaning like you don't know where you are in space. So like if you close your eyes, you like start swaying all over the place because you're like, I can't figure out where I am if I'm not looking at something. That's proprioception. So you get these neuro symptoms with B12, but not with B9. So there's these two things that differentiate B12, B9. Also the source of where the food, like kind of read the vignette and be like, okay, does this sound like a vegan situation? Like no animal products? Also older people also tend to have B12 deficiencies because they don't have as much like animal products as they get older. As people get older. B9 is found typically with the vignette, they'll talk about like an alcoholic or someone with really bad nutrition or something like that. And then very briefly, because this is hem-onc to a T, but I have to mention it because this is how it presents clinically. It presents with what's known as megaloblastic anemia. So anemia just means like there's decreased red blood cells. That's what anemia means, decreased red blood cells. And how they characterize that clinically is they look at the hematocrit. So if you have decreased red blood cells, they can say there's decreased red blood cells, or they'll just say there's a low hematocrit or a decreased hematocrit. Same thing. But megaloblastic, the red blood cells are massive. They're very, very large. So think of like mega. And they look at that with what's known as an MCV. So this is like what's the mean volume basically of these red blood cells, and they're big, so it's elevated. We have an elevated MCV. So we have anemia, we have very, very large red blood cells, and then we have what's known as hypersegmented neutrophils. We will go into this in immuno. We have like a whole day where we go through, a whole session where we're going to go through all the different peripheral blood smear findings. But this is a neutrophil. Neutrophils should only have 3 to 5 lobes in their nucleus. So these dark purple, this is a nucleus. So there's 1, 2, 3, 4, 5, 6, 7, 8, 9. This is a hypersegmented neutrophil. So that just means like there should be 3 to 5 segments to the nucleus in neutrophils. This has hypersegments. There's more than 5 segments in the neutrophil, okay? And then the last thing is the elevated homocysteine. Remember, that's going to be elevated B9, B12. It doesn't matter. Homocysteine is going to be up. Do you get Heinz bodies? Great question. No, you don't get Heinz bodies. Very good question. You actually get Heinz bodies. I don't know if you guys have learned that yet. No, I'll just leave it there. You'll go into it in hemo. We'll talk all about Heinz bodies in hem-onc or immuno, but no Heinz bodies here. So again, folate deficiency, hematocrit's going to be up. Down. Anemia, it's going to be down. B12, it's going to be down. Your MCV, so remember, this is how big the red blood cells are. That's going to be up, and it's going to be up in both. Homocysteine, remember, that's going to be elevated in both because both are involved in that DNA synthesis, like that methionine cycle. Methylmalonic acid, remember, in folate is going to be normal, but in B12, that's going to be increased. Here's your first big difference. And then neurological symptoms will be absent from folate deficiency patients, but they will be present in your B12 deficiency patients. Okay? All right. And then kind of before we go into like the vitamin clinical vignette questions, I wanted to briefly mention kwashiorkor versus marasmus. This I feel like they will ask you because this is a GI/nutrition block. This is nutrition. They also will probably ask you about like calculating calories or something, like using a dietary something to calculate calories. It's in first aid. So I would look at that as well because that's technically nutrition. So there probably will be nutrition questions on your exam. But this, I almost guarantee they'll ask this because these are just funny words. But kwashiorkor, so both of these are obviously some sort of nutritional deficiency. Kwashiorkor specifically is when you have decreased protein. That is the main issue with this, is the body is sensing that decreased protein, and it's basically responding to not having protein. So the first thing you should be thinking of is, I don't have protein, I don't have oncotic pressure, my oncotic pressure's down. So now you can imagine all the blood vessels, there's nothing holding the blood in, and that's how you get third spacing or edema. Nothing's holding it in, it's all going to kind of shoot out. So you get edema, especially in the abdomen, the legs. So you can see here in this child, they're very thin, but they have a swollen abdomen, they have swollen feet, and it's all because of that decreased protein. The decreased oncotic pressure is causing these symptoms. versus marasmus. Marasmus is when it's like you just have a strict caloric deficit. The body's like seeing the calorie deficit, and that's all it's seeing. It really, well, and in this instance too, it's probably like how I kind of think of this is like with kwashiorkor and marasmus is protein is the issue with kwashiorkor. Marasmus is kind of like everything is down. So it's like the body's like, oh, this is an overall caloric deficit. So I'm not going to have edema. But I'm going to have what's known as muscle wasting and fat wasting. So I remember with marasmus, there's muscle wasting, and then you can see kind of this clinical image where it's like a very, very thin child or a very, very thin person. Everything's down. There's no swelling. There's nothing like that. Okay, so fat gets broken down, muscle gets broken down. Yeah, and it's decreased caloric intake versus decreased protein. All right, cool. All right, so I have some vitamin questions. And just a preface, I didn't write these. Some of these are from Amboss, but I didn't write the ones that are just like text. I got them from like this biochem book, like this clinical biochem book that I used during board studying. Oh yeah, sorry, this is low. Sorry, I forgot. You guys don't have reference ranges, so this hemoglobin is low. Okay, let's go over this one just so we can get to the biochem stuff. So this one is going to be elevated methylmalonic acid. So very good. This is basically this is a little trickier because they didn't talk about like a vegan or anything, but they do talk about the kind of the B vitamin symptoms and then all those neuro stuff, and then there's also decreased like basically anemia. So there's your elevated methylmalonic acid. This is your B12 deficiency. Okay. All right. All right. Next. And like I said, these are from a biochem board studying book. So these are very similar to the types of vitamin questions you'll see on boards. All right, let's do this one. A lot of you guys answered. All right, so this one, this is like a classic board style thing where you can just read the last sentence and they'll kind of tell you kind of like what they're looking for. So it's kind of like which of the following symptoms would be indicative of marasmus? muscle wasting, right? Marasmus muscle wasting. So that's this one. And then which vitamin deficiency is likely causing his rash? And now it's like, okay, I got to go back and read. But upon first glance, I see corn-based meals, and I'm like, nice. And I'm telling you, they'll say this when they want you to pick niacin. So remember, and imagine that these options were all, thiamine, riboflavin, niacin. So just make sure you know the B vitamin and the name. But yes, oh, I did do that. And then I also just put on here, remember vitamin A can also cause a skin rash. But again, that wasn't an option here. But remember that niacin deficiency usually presents with this triad versus vitamin A. It's usually the night symptoms, and then you have the rash as well. Marasmus, yeah, no worries. So marasmus very quickly is going to be the decreased caloric intake. So just overall decreased caloric intake versus something like kwashiorkor, which is going to be decreased protein specifically. So they're both like nutritional deficiencies, but they present a little differently. So like if you were kind of between marasmus and kwashiorkor, for this one, it would kind of be like I would pick, enlarged abdomen, or I don't think they would have both of these if it was kwashiorkor, but that would be more indicative of like a kwashiorkor. And they could have easily changed the question to ask that. Because again, it's dependent on like what the body sees. Does it see the caloric deficit first, or does it see the protein deficit first? All right. Okay. You guys did that so quick. I'm so proud. Yes, good. So this is vitamin K. This is your classic vitamin K. Newborn starts bleeding. Vitamin K. Also could have just been like a normal person on antibiotics. And they bleeding, obviously. All right. I know you guys are probably between two with this one. But I'm gonna go so we can keep going. But this one is thiamine. So I should have put it in option F and had glucose, but none of you guys would have gotten gut because I know you wouldn't have. But this is your classic Wernicke-Korsakoff. Oh yeah, no problem, no problem. Yeah, whenever you guys have to go, go for it. Um, so this is your classic thiamine. Another thing that really helps with this is like he still shows signs of intoxication, but it's technically he's sober. That's like this is like an irreversible type thing. So this is kind of how Wernicke-Korsakoff presents. Again, in neuro, we can go into it a little bit more about Wernicke-Korsakoff. But yeah, very good. Thiamine, awesome. Last one, and then biochem. Is that how it differentiates from beriberi? Yes. That's kind of how it, like, once you start getting those, like, confabulations, ataxia, like, that kind of goes from dry beriberi and, like, wet beriberi to, like, okay, now we're at Wernicke-Korsakoff. That's, like, that irreversible type of thing. Oh my God, you guys don't even need me. You guys are all little nutritionists things. Yes, so very good. You guys got this. So this is a B12 deficiency, strict vegan for 2 years. Usually won't be this obvious, but I was shocked it was in the book like this. But yeah, and you can see the vitamin B12 deficiencies. They're talking about she's lightheaded, she has tingling in her hands and feet, like very neurological symptoms. So less B9, more B12, as well as being a vegan. That's B12. And then what else would you see? You would also see megaloblastic anemia. Awesome. Okay. The fun stuff, biochem. All right. So kind of the same thing. I took some Amboss questions, but also some from that book, that step one book. This one's really long. I'm so sorry. It's long. Oops. Okay. So I think I'm gonna go through this one. I'll give you guys like 5 more seconds. All right. So with this, they basically tell you that they suspect lactose intolerance. So with lactose intolerance, they're basically saying this patient can't digest lactose. So it's basically asking where the enzyme that would digest lactose is located. That's kind of like just where's lactase, basically. And in the small intestine, where lactase is at the luminal epithelial cell. So here's kind of like a little diagram that I drew. So here is, so we're in the mucosal layer of like the late duodenum, upper jejunum. And basically what we're doing here is, here's your villi. So remember, small intestine have tons of little villi on it, and it helps to increase surface area, whatever. The villi have enterocytes lining, and I didn't put them all the way because I just didn't have enough time to do it. But there's enterocytes lining all of these villi, and then each enterocyte has microvilli. And then if you were to zoom in on the microvilli is covered with a bunch of different disaccharidases. So the enzymes that break down disaccharides. So like this one would be lactase, this would be maltase, sucrase, isomaltase, for example. Each microvilli has just tons of those on it. And it's just important to know. So these are your brush border enzymes. When they reference like, oh, your brush border enzymes, they're talking about these disaccharidases on the microvilli, on the enterocytes, on the villi in the small intestine. Okay. Oh, good. I'm glad. I'm glad. It's like, I hate like location questions, but sometimes it's like, oh, that's actually important to understand the disorder. So basically, what these disaccaridases do is they provide that final digestion before absorbing. And the big location here is they're found on the luminal side of the small intestine. And again, hopefully that makes sense, because remember, it's kind of the same as like from renal. I always remembered basolateral blood. So it's like the basolateral side is closest to like the blood. The luminal is facing the lumen. And remember, with the small intestine, the lumen is going to be where all the food is and where all the food can be digested and whatever. Okay, so what's the answer? So if we go back, it's like, where would the affected area appear? So basically this is saying the disaccharidase that's deficient here, lactase, would be deficient on the luminal side of the epithelial cell. So they're saying, like, basically that's where you can find these disaccharidases because they're on the microvilli, which is on these epithelial cells, which are the enterocytes, but on the luminal side. And then remember that we can only absorb monosaccharides, we can't absorb disaccharides, and that's why you can get like lactose intolerance because you can't break down lactose. Another thing that I'm pretty sure they will ask you on your exam, so just make sure you do this before, is know what makes up each disaccharide. So like, for example, know that lactose is made up of the monosaccharide glucose and the monosaccharide galactose. Just like know that for all of them. What makes up maltose? Like just kind of go through that. But basically, here is lactose. It undergoes digestion from lactase, and then it comes out as glucose and galactose. And then remember, that can get reabsorbed by GLUT2, right? So GLUT2, and then it gets reabsorbed from GLUT2, and then it gets reabsorbed basolateral side back into the blood. Cool? All right. Any last burning questions with this one? All right. Next. All right, I'll give you guys like 10 more seconds. Okay, you guys are biochemists. I'm so proud. Okay, so very good. I think you guys all got this one. So she's examining a. Where's everyone putting their answers? Oh, sorry, they're just sending them to me directly. And I always encourage that because it's like, I don't care what you guys say. I just want you guys to like try it. Okay, so very good. So red blood cells. So if she were examining a population of red blood cells, which of the following compounds would be most enriched? So this is kind of just trying to get at the fact that you understand that red blood cells, no mitochondria. They can't undergo like certain processes. Well, not even no mitochondria. They just can't, they just can't undergo certain processes. The only thing they can really go through is glycolysis. So they can only produce ATP via anaerobic metabolic pathways, like glycolysis. So then it's like, what's the final product of glycolysis? Pyruvate. And then on, why did I have this other slide? I don't know. Okay, does that make sense? I think you guys all got it, so I think you guys understood that. But yes, just remember that red blood cells, no mitochondria at all, so they can only really go through, they can only make ATP via this glycolysis pathway. Okay, cool. I'm sure you guys hate glucose transporters like I did, but these are very important. They love glucose transporters. All right, I'm so glad I'm getting all of the glucose transporters because I love that you guys hate them as much as me. I'll give you guys like 10 more seconds. Okay. So, another way that they could ask this question basically is which of these glucose transporters is acted on by insulin? That's pretty much it. And if you guys, we're going to go through it right now, but GLUT4, only glucose transporter that's dependent basically on insulin to uptake glucose. All the other ones do it, like they'll just do it without insulin. Another kind of hint is that it's talking about muscle cells. So remember that GLUT4 is found on muscle cells as well as adipose tissue. Okay, but we're gonna go through it. But that's kind of what they were getting at here. I agree, it was kind of like a weird way that they worded it. But that's like why I wanted to bring in clinical. I could have just asked which of the following glucose transporters is acted on by insulin. But this is kind of like how they be tricky with biochem questions. So it's kind of like insulin only affects glucose uptake with GLUT4, if that makes sense. But we're gonna go through it. So insulin dependent glucose uptake. And what this means is that these glucose transporters will not uptake glucose if insulin is not telling them, hey, you need to uptake glucose. So GLUT4 is found on your adipose tissue and basically your striated muscles. And I put here exercise because this is also why exercise is kind of like really good, because it's like sorry, not really good. I did that opposite. It kind of makes sense with exercise that you need the muscles and the adipose tissue need to break down glucose. They need energy to exercise. So it's kind of like it makes sense, like, oh, this is triggered during exercise. Like you would get insulin triggering the uptake of glucose for the muscles to make energy, basically. And you don't want your muscles to just be like using, you know what I mean? Like you don't need that unless like insulin is telling it to happen. We'll go through it. So insulin hormone interacts with its receptor, which is a tyrosine kinase. Definitely know that insulin's receptor is a tyrosine kinase. And I bring this up because insulin and glucagon, they're kind of like opposites, right? Glucagon acts through a G protein coupled receptor. So, cyclic AMP gets upregulated, it acts through PKA, blah, blah, blah. Insulin, which should be like its counterpart, does not act through a G protein coupled receptor. It acts through a tyrosine kinase receptor. And tyrosine kinase receptors, they're little dimers. So here's one half of the dimer, here's the other half of the dimer. And when insulin binds in this little groove here, so here's insulin, these dimers will dimerize, so they'll come together, and then it undergoes this process of phosphorylation. So phosphorylation happens, and that's when you get this downstream effects. And sometimes, because with glucagon, it goes through like the cyclic AMP pathway, PKA gets activated, blah, blah, blah. It goes through what's known as the phosphoinositide 3 kinase pathway. So you'll see this abbreviated as PI3K. So the PI3K, this is how insulin like upregulates GLUT4 receptors, basically. It also undergoes this pathway. This isn't as important for what we're talking about with glucose. Insulin's very anabolic. It helps with like building and like growth. Like that's how you should be thinking of insulin. It's very like growth and anabolism, versus glucagon is the opposite. But for this purposes, for glucose stuff, we get the phosphorylation and then we undergo the PI3K pathway. And that's when we basically get GLUT4 receptors getting put on the surface of your muscle cell, your adipose tissue. Okay, so insulin binds, which will induce glucose uptake into insulin-dependent tissue, adipose tissue, skeletal muscle. Then remember that GLUT1, 2, 3, and 5 are going to be insulin independent, meaning that they don't need insulin to tell them to uptake glucose. They'll just do it. Like they'll just uptake glucose. And then, so remembering like which cells have GLUT1, and I know this is where like the GLUT receptors lose me when I'm like, oh, I have to memorize. But you should know which cells have which of these receptors on it. So GLUT1 is here, GLUT2 is here, GLUT3, and then GLUT5. I put on here this mnemonic that some people use. It doesn't help you differentiate GLUT1, GLUT2, GLUT3, GLUT4, GLUT5, or GLUT1, GLUT2, 3, and 5, but it at least tells you which cells are insulin independent. So the mnemonic is BRICLIPS, and it's like brain, red blood cells, intestine, cornea, kidney, liver, islet cells of the pancreas, placenta, and spermatocytes. Um, oh, sorry, I missed some of these. So how come when you eat, you have elevated cyclic AMP? Hmm, when you eat. So it's probably not glucagon related. I'm not exactly sure why you have elevated cyclic AMP. Probably because I don't actually know. I actually don't know. I can look that up for you and figure it out. I'm not sure. I just know as soon as you eat, insulin gets upregulated, and then this process kind of happens. Probably because of histamine. Yes, histamine is GS. Yes. Yeah, so probably another one of those GS things do get activated, but for sure, as soon as you see like eating, boom, insulin, and then you should be thinking of this automatically. So what you put in there is perfect. Any insulin question, think about building and glucose utilization. Perfect. Glycolysis and anabolism. That's exactly what you should be thinking as soon as like anyone eats any food or takes insulin. Yes, histamine is GS. There's tons of you guys will go in, you will hate the G proteins when you go into endo because you have to know all of those, like all like, oh, histamine's GS. Oh, this one is this. It's annoying. But anyway, so does this make sense? So insulin dependent means that these cells cannot uptake glucose without insulin. They just won't do it. So it's kind of like a regulatory mechanism by the body. It's like I don't want the muscle cells in the adipose tissue to uptake glucose if I don't tell it to. If there's not plenty of glucose around, I don't want them uptaking it. So that's kind of the idea behind GLUT4. GLUT1, 2, 3, and 5 are all insulin independent, so they will just uptake they don't care. They'll just uptake glucose without insulin telling it to. So here's like this chart that I made, and this was GLUT4 for this question. This is your insulin dependent. And I only put major, so I didn't include like GLUT5 on here because that's more so for like fructose for sperm, which again you'll go into later. But these are like the major ones, 1 through 4, kind of like understanding what tissues they're located on. It's important to understand brain and red blood cells. I think I talk about that on the next slide. But in terms of like the kinetics, sometimes they can tie in like the true like the throwback biochem with like, oh, Vmax and Km. So we'll go into that. But notice that the lower KMs will have zero order kinetics versus your higher KMs will have first order kinetics, which we will talk about. Another important kind of note over here is that GLUT2 is kind of like your pancreatic beta cell glucose sensor. So it's like, okay, like the pancreatic beta cell, that's making insulin, right? Like that's what's secreting insulin. So it needs to be able to sense how much glucose is around. Should I be releasing insulin? Like, is there glucose? That means we need insulin. So it does that kind of through GLUT2. And then 1 and 3 are very similar, like very similar. They just basal uptake of glucose, meaning like they're just uptaking glucose all the time. Like nothing is telling these cells to uptake glucose. They're just doing it at like a basal level. And then we talked about GLUT4 already. So kind of going into the kinetics because biochem. But so just kind of going through the Michaelis-Menten type stuff. So Km and Vmax. So remember that Km is the concentration of the substrate, which in this case would be glucose, which basically allows the enzyme to reach half of its maximal velocity. So Km is going to be an x axis value. So my Km would be like this in this example. So basically you find where 50% of the maximal, like how quickly the enzyme can work if it was working maximally, you find that Vmax value, and then 50% of it, what's that concentration of substrate, aka glucose? And it's right around here. That would be the Km. If you have a lower Km, so like closer like to 0, like on this side, a lower Km means that you're getting to Vmax quicker versus a higher Km, like let's say all the way over here, that means you're not reaching like half of your Vmax until like all the way over here. So this is like you're moving towards Vmax a lot slower if you have a higher Km. So Km and Vmax, these are like about the enzyme itself. It's like what are the qualities of the enzyme itself? And then, yeah, let's say the enzyme is fully saturated by the substrate. How quickly is it working? So that's Km Vmax. So tying this into kinetics, so first and zero order and first order kinetics, this is kind of like how graphs would look. So if we kind of take our Michaelis-Menten plot here, and this is plotting the reaction rate on the y-axis and then drug concentration on the x-axis. This is doing the same thing, rate and concentration. Zero order means that basically this is telling me concentration doesn't matter. Like the enzyme's going to work at the same rate no matter what the concentration is. It can be low, it can be down here, it can be high, it can be all the way up here. The enzyme's working at the exact same rate. And if you remember, these are the really low KMs, have zero order kinetics. If I go back to my little chart here. So like 1 and 3 are good examples. So 1 and 3, they have like 1 millimeter of like the KM's really, really low. And that's why they have zero order kinetics. And hopefully that makes sense. And I put this here because like, why would well, before I ask that question, you guys can think about it. But zero order kinetics is basically telling me this enzyme is transporting glucose at a constant rate no matter what the glucose concentration is. This person could have just had a meal like right now and the glucose is all the way up here, or they haven't eaten in like 5 hours and glucose is all the way here. But my red blood cells are still getting the same amount of glucose. My brain is still getting the same amount of glucose. What are some other ones? Well, most tissues. But they're all getting the same amount of glucose no matter what the concentration of glucose is. So my question is, you don't have to answer this, but just think, like, why does it make sense for cells in the brain and red blood cells to have like zero order kinetics? Like, why would they have GLUT1 and GLUT3s? Yes, yes, exactly. We need to live. Precisely. Yeah, you always need it. Like, the brain, and another thing too is like the brain cannot, and I don't know how, yes. Oh, perfect. Oh, you guys are also my biochemists. Yes, so great answer. So someone goes, they rely solely on glucose. Exactly. The brain can only use glucose as its energy source. And before you come at me, yes, it can also use ketone bodies. That's the whole point of going into ketoacidosis. Thank you. Thanks for keeping me on track there. They can also use ketone bodies, but for the most part, they will use they want to use glucose. They don't really want to use ketone bodies. They're like, fine if they're around. They're like, all right, fine. But the brain, only glucose. Red blood cells, same thing. They don't have mitochondria. They can only go through glycolysis. That means they can't go through fatty acid metabolism. Like they can only use glucose. Make sense? So if you're thinking about this just logically instead of memorizing like, oh my God, first order, second, blah, 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 biochem, Michaelis-Menten, just it makes sense that like no matter what, the brain and the red blood cells, they need glucose transporters that will just take up glucose no matter what the concentration is. Because again, we need to live. Like we need to live. All right? That's my little tangent. That's my little GLUT1 and GLUT3 tangent. But that's kind of the point of that. And then your first order, oh my God, first order, guys, this is like a GLUT2. Think of what has GLUT2, your pancreatic beta cells. They're sensing, is there glucose? Like, is there glucose around? If there is, I need to make insulin and release insulin. So this is kind of like saying, all right, if I have first order, that means if I have a low concentration of glucose, the enzyme's going to work kind of like at like an equally low rate. If I increase my concentration of glucose, it's going to start working a little bit quicker. If I have maximal levels of glucose, it's going to work all the way up here. So this is like the Km value would be all the way over here. So it's approaching Vmax slower, but it's dependent on the concentration of the substrate, which is glucose. So the more glucose that's out in the blood, the more that GLUT2 can uptake. And basically it's like telling the pancreatic beta cells like, hey, there's tons of glucose around. Like you need to release some insulin. So that's why GLUT2 has a very, very high Km value. And this is basically saying glucose will really only enter cells because that's when the enzyme is working, like that's when GLUT2 is working like at its maximal level if it's present in high enough concentrations. Okay, that's like when it's going to start actually coming into the cells. That's when like the beta cells are going to be like, okay, cool, yeah, I need to make some insulin and secrete it. Does that make sense? So know these, learn these, love these, just every single question they can ask about them, kind of understand how KM fits into the kinetics, why it makes sense that lower KMs are for like those zero order kinetics versus higher KMs are for those first order kinetics, and why the cells that have them make sense. And then insulin dependent, insulin independent. Just know everything about these glucose transporters. But don't freak out if you see little Michaelis-Menten plots on it'll be fine. Okay. All right, next question. This is kind of my plug if you guys haven't done glycogen storage diseases yet. This is my plug to be like, yes, go do those. Okay. So let's go through this. So remember with glycogen storage diseases, look at like the age. Sometimes that'll help you. And then look to see if there's lactic acidosis or not. That'll also help you. But luckily, this one told you the exact enzyme that is deficient. So that's also something to know about these. So this one, that's missing glucose 6-phosphatase, which is the characteristic of von Gerke disease. So von Gerke disease, you're missing glucose 6-phosphatase, and then you get all of these symptoms. So we're going to go into why. So this is glycogen metabolism. So remember, glycogen storage diseases is either there's an issue with glycogen itself, or there's an issue with basically using glycogen for energy. That's what these glycogen storage diseases are. Like, they usually fall into one of those two categories. Remember that glycogen is super branched, like it's this massively large, giant, massive structure. And the point of that is to kind of be, very osmotically active. But regardless, here's our glycogen, so now it can get stored. And then here's our glycogen, and it can get broken down by all these different enzymes. When we're in the liver, and that's why you do see hepatomegaly with von Gerke, glucose 6-phosphatase breaks down this glucose 6-phosphate into glucose. And now the cells can use glucose. That's like how you're able to use glycogen. That's how you're able to get glucose from glycogen. And then for von Gerke disease, obviously this is the enzyme that would be deficient for it. So this is an inborn error of metabolism. And whenever you see this term, I used to think that this was like an absurd term. I was like, what? I don't even think the people that came up with this term know what that means. But basically what they're saying with an inborn error of metabolism, they're saying like this is a hereditary condition where some aspect of metabolism is affected. So technically breaking down glycogen to use as energy is a source of that is a metabolism thing. So this is a hereditary issue with some aspect of metabolism. So you'll see like a lot of, like, you'll just see this term randomly. It's an inborn error of metabolism. I even think like, which one did we talk about with tryptophan? I already forgot. But that would also be like an inborn error of metabolism because, yeah, you can't make niacin. Oh, heart and up disease. So when you see that term, that's really all they mean. But for these, it's usually babies and very young children. So a lot of the time, that's how you know that they're talking about like one of these inborn error of metabolisms. But with glycogen storage diseases, you're missing one of the enzymes that breaks down glycogen. So it's either like glycogen will build up in the liver because that's where it's being stored, or it's just glycogen is not forming properly. Like one of those enzymes is affected that is affecting it. There are many glycogen storage diseases, but the most common is 1, 3, and 4. And von Gerke, another name for it, and the reason I say 1, 3, and 4 is because sometimes, and this is more like a Comlex thing, I didn't see this on STEP, but on Comlex especially they did this, they wouldn't say von Gerke disease, they would say glycogen storage disease type 1. So if you're like, well, I know it's von Gerke, but I don't remember what type that is. So definitely that's why I kind of tried to interchangeably put that on here, like whenever, yeah. So just kind of have those types down. But with von Gerke, it's a glucose 6-phosphatase deficiency, so you can't take glucose 6-phosphate and turn it into glucose for use. This is one of the most common ones, but again, since glycogen itself is fine, you just can't break down the glucose 6-phosphate into glucose, it's kind of like the glycogen structure is fine, but now we have increased glycogen storage because we're not able to break it down. Okay, so that's kind of the problem with von Gerke. And this is kind of like a good way to kind of go through all the glycogen storage diseases and be like, is this a structure like issue, or is this like a storage, not even a storage, it's like a functional use issue with the glycogen. I also recommend making like little charts like this. So what's the deficient enzyme? And then, so for von Gerke, what's a deficient enzyme? What are some clinical features? And then is glycogen synthesis affected? Here we know it's not because it's just the enzyme that breaks down the the glucose 6-phosphate into glucose is what's affected. But here, the clinical features, there's severe hypoglycemia. Like this is like the most common thing that you see. You see lactic acidosis, hepatomegaly, hyperlipidemia, and hyperuricemia. And I have a chart that shows like why you see all these features. And then you see some other stuff. This is like not as specific for von Gerke, but it can help you with diagnosis that, oh yeah, this is a glycogen storage disease. So like short stature, doll-like faces, protruding abdomen, and emaciated extremities. A lot of the times whenever you have hepatomegaly, you're going to have a protruding abdomen. It's just like, that's like the liver gets bigger, the abdomen is going to stick out a little bit more. So here's like your typical child with von Gerke disease. So they look kind of like like a normal kid, but then they have like this massive like swollen belly, and it's from the hepatomegaly. Um, so with this, glucose 6 phosphate, which is or phosphatase, which is located in the liver, removes a phosphate group from glucose. Then now the glucose can leave, because remember that phosphate groups gets put on glucose, so it can't leave. And then once you remove it, now it can leave and it can go into the blood. So that's why if you don't have this enzyme, you can present with hypoglycemia. And a lot of the times too, like glycogen kicks in without us like realizing it. Like if you don't eat all day, you can kind of like, you can just straight up be like, oh yeah, I'm hypoglycemic. Like you can be hypoglycemic, but a lot of the times it won't really happen. Like it really won't happen because you have normal glycogen use. The hepatomegaly is going to be due to the accumulation, because now we have, remember, that's kind of why it's like important to kind of be like, oh yeah, the increased glycogen storage, that's kind of where you're getting that hepatomegaly. Glucose 6 phosphate is osmotically active, so it's going to pull in water. A lot of the times when you have like a storage issue with these glycogen storage diseases, you're going to have hepatomegaly. And then lactic acidosis here is due to pyruvate buildup. And yeah, some of you guys are even saying like, oh, like this was key in differentiating this disease from this disease, 100%. And that's always going to be in a vignette to help you differentiate one from the other. And that's why they really like glycogen storage diseases, because it's kind of like you need to like understand like, oh, like in, von Gerke, for example, you're going to get pyruvate buildup. But in like Cori disease, for example, you won't. So like that's a very important differentiating factor between those two, or something like that. Like even hepatomegaly, like that's not going to affect like if you have normal glycogen structure, like you're not going to get a buildup. You're just not able to use it. So little things like that is going to help you differentiate between these different diseases. Facies, yes, yeah. Oh, sorry, I didn't even mention that. It's like this becomes like just like a normal term that's just gonna start getting thrown around with pathology. Doll-like facies. So when they say this, they basically are saying like if I don't even exactly know what facies is, but when they talk about that, they mean like the face itself is like very swollen and it's like small. So it's like small and swollen. That's like the term like what for when you see like doll-like facies. Yeah, I'm not really exactly sure. It just becomes like a term. You're like, oh yeah, there's the facies again in this disease as well. And that's why I didn't highlight it in red, because again, this comes up in a lot of different disorders. I even think in like Down syndrome, they say something about like having like doll-like facies or something like that. But okay, so here, so we talked about lactic acidosis, we talked about hyperglycemia, hypoglycemia, and what was the other one? Oh yes, the hepatomegaly. So now it's like, why do we get hyperlipidemia? So with hyperlipidemia, the hyperlipidemia is going to be secondary to hypoglycemia. So now the patient is hypoglycemic because there's, no glucose around, they can't break down glycogen. So what's the body do to respond to hypoglycemia? They release glucagon, they release epinephrine. So as soon as glucagon and epinephrine get released, they go to the adipocyte, the fat cell, and they activate this enzyme called hormone sensitive lipase, HSL. What hormone sensitive lipase does is it basically takes triglycerides and it breaks it down into fatty acids. And now the body's like, cool, I'm going to use fatty acids as energy because I can't use glucose. But that's all dependent on glucagon and epinephrine acting on hormone sensitive lipase. And I put the little P here to remind you that glucagon and epinephrine phosphorylate things like to activate them. And then don't forget that insulin is the weird exception. It dephosphorylates things to activate them. So I always like to remember, I always try to like, whenever I can throw in that little plug with glucagon and epinephrine, be like, oh yeah, remember, they phosphorylate. Now it's going to activate hormone sensitive lipase. Okay, cool. So then the fatty acids are going to be in the blood, and there's your hyperlipidemia. And then hyperuricemia is because we're going to have excessive uric acid from the pentose phosphate pathway. And because uric acid is a breakdown product of protein metabolism. And I just wanted to show you, here's kind of like a pathway, like I found, just showing like all of those things. You see hyperuricemia over here because of the pentose phosphate pathway. You see the hypoglycemia here, hyperalaninemia, you also get that. But you can also get that in some of the other ones, lactic acidemia, and then hypertriglyceridemia. All right, so this is the one that's deficient in von Gerke's, and that's why you get all of these different presentations. And then kind of like I actually think someone put this in an LI when they were doing it when I was a first year on how to remember von Gerke. And they said, like, oh, think of it as von Geek disease. I guess this is a character from The Simpsons. I don't really watch The Simpsons, but they're like, oh my God, that's so helpful. So I wanted to at least put it here. So they said this character is fat, has no muscle, and has fatty liver. So there's hyper. Oh, Dirty Medicine did that too? Nice, perfect. Yeah, Dirty Medicine is really good for like memorization things like this. So fat, hyperlipidemia, no muscle, hyperuricemia, and then fatty liver, hepatomegaly. All right. All right. I have two more questions, but I really want you guys to do this question because I think this is the best question. And then the last question will just be like it's like something you should know if you haven't studied it yet type of thing. Oh my God, guys, we're at a 50-50 split, which I love. I'll give you like 15 more seconds. Okay, let's do this. You guys only were between two. All right. So basically, this question is again, all this question is asking is what is insulin gonna do? Like, what does insulin do? Well, not even what does insulin do. It's basically saying, like, remember we talked about insulin earlier? We were like, when you think of insulin, what do I want you to think of? I want you to think of anabolism, and I want you to think of these certain processes in the body. So this answer is actually going to be, drumroll, A. So the half of the people that picked A. Yeah, it's literally 50% of you. It's hilarious. It's like equal. So awesome. Yes, a lot of you guys switched from A to C. A lot of you guys picked C. So we're gonna talk about this. I think this is a really good boards-ish style question. This is what boards does. So the key to this question, so this is something that I drew because I kept getting questions like this wrong. Like basically this is a fed or fasting state question. And no matter what biochem you guys have done at this point, there is a chapter in Lippincott. And I hate Lippincott, so the fact that I'm telling you to read it, like not even a chapter, it's a section in Lippincott. The fact that I'm telling you to read this Lippincott section is important. So there's this little section in Lippincott. I think it's literally called like the fed and fasting state. I think and Boards and Beyond has like a short video on fed and fasting state. They love fed and fasting state. And so basically like I drew this out and I vowed to never get a fed and fasting state question wrong. And so this is kind of like the key to it. So understanding that glucagon, epinephrine, they act almost identically. It's just epinephrine is found on liver and muscle, and glucagon is only found on the liver. Remember that your glucagon receptor and then your beta receptors that epinephrine bind to are going to be G protein coupled receptors. They're G alpha S, right? So they're GS. So they make cyclic AMP, which activates protein kinase A. And then from here, protein kinase A is going to activate glycogen phosphorylase kinase, which does exactly what it says it does. It's going to, so it's a glycogen phosphorylase is the enzyme, and it's a kinase. So it's going to phosphorylate glycogen phosphorylase, oh my God, which is going to basically take glycogen and phosphorylate it into glucose, okay? Hopefully that makes sense, because the whole point of glucagon is to increase levels of glucose, and it does so through this pathway. It goes through cyclic AMP, protein kinase A, glycogen phosphorylase kinase to make glycogen go into glucose. On the opposite side over here, we're going to go all the way over here to insulin. Insulin has its tyrosine kinase receptor. It's going to dimerize. It's found in liver and muscle. Well, the insulin receptors are found in liver and muscle. It's basically going to work directly through, we talked about it, the PI3K pathway, and eventually it's going to act on glycogen synthase. It's going to synthesize glycogen, right? Anabolism. We want to store all this extra energy we have around. Another thing that it can do is it can activate this enzyme protein phosphatase, which is going to just further activate glycogen synthase, okay? Okay, and then we have over here epinephrine again. It can also bind to alpha receptors. So how do alpha receptors kind of play into this? They kind of act exactly how glucagon acts, right? It's like what it's going to do. All right, so the point of this picture is to kind of show no matter what they ask, you can kind of figure out, no matter what weird enzymes they ask, they can kind of throw into this. You can be like, oh yes, glycogen synthase is getting activated from insulin. Glycogen phosphorylase is getting activated by glucagon. So glucagon and epinephrine, think catabolism. So think we want to use glucose. So we're breaking things down. So when the body needs energy, that's when glucagon and epinephrine both get released. It's going to inhibit any anabolic process via PKA. So here's PKA inhibiting this anabolic process that insulin's activating. And it's going to be, aka your fasting state. This has a point with the question, I promise. Over here, insulin, automatically think anabolism. So there's anabolism. I want to make glycogen. I have so much glucose around. Yes, I'm sending it off to glycolysis, but I also want to store all this glucose I have around. So think of synthesizing glycogen, synthesizing fatty acids. So insulin gets released when the body has energy. It's going to inhibit catabolic pathways, and it does throw with its PI3K pathway. This is your fed state. So all of this to basically say that it's saying insulin gets released. Which of these processes is involved in the fed state? And we know that fatty acid synthesis is involved in the fed state. So that's why this would be the correct answer. And we'll go into it a little bit more. Here are some memes because I hate these enzyme names, but it's kind of like just people laughing at how absurd that these enzyme names are. Little comedic relief for some biochem, which you guys can go through later. But here's kind of what I was getting at. So with fasting, glucagon gets released. It acts through its GS pathway. Bunch of stuff happens. We went through all those G protein stuff. You're going to get increase in hepatic gluconeogenesis in the fasting state. You're going to get gluconeogenesis. In the fed state, think insulin, you get your PI3K signaling, which eventually is going to decrease gluconeogenesis because it's you don't need to make glucose. We have tons of glucose around. Let's start storing it. Let's start building things up. Let's start synthesizing. So let's make fatty acids. Let's make glycogen. Let's do all that stuff. So if you kind of think about this here in this example, and I know glycogenolysis, breaking down glycogen is tempting because you're this is fed state, but the body doesn't want to do it. When insulin's released, the body's I don't need to use glycogen into glucose, right? I don't need to undergo this process of glycogenolysis. So this was kind of a tip that I realized when I was studying for boards, that instead of memorizing just oh man, what is insulin? Where exactly is insulin working? Just think fed fasting. Am I making fatty acids when I'm fed or when I'm fasting? When you're fed. When would insulin be released? When I'm fed. Whereas all of these other things are involved in the fasting state. So this is your fatty acid. This is your beta oxidation, right? Your fatty acyl-CoA to acetyl-CoA. That's your oxidation. This is your glycogenolysis. And then this would be your gluconeogenesis, your OAA to your PEP. Does that make sense? This was a tricky one. My C people, does it make sense why A makes sense in this kind of scenario? And that's exactly, and even in I don't have because again, this is from that biochem textbook, right? That little biochem workbook for boards. Even in that, they were think about when you see insulin in a question, your mind should automatically go to building things up. Like, I want to build up everything because I have tons of glucose, I have tons of energy around. And then I want to inhibit all of the fasting processes because I'm fed, I'm happy. Versus if this said injection with glucagon or something like that, it would be like, not all of these would be there, but one of these would be the answer, regardless if glucagon is directly even working on one of these pathways. And the reason why it's like it's not directly working on any of these pathways is because a lot of the times insulin and glucagon just work on like these intermediate enzymes. Like, they'll work on like these guys, like protein phosphatase, glycogen synthase, blah blah blah, glycogen phosphorylase kinase. Okay, so that was a tricky one. That was a tricky one, but fed and fasting, very important. Watch the Boards and Beyond video on it if you have, or just watch it again, and then read that little Lippincott section on it. It'll just kind of go through this again a little bit. And then this is the more technical stuff of the actual enzymes. All right, and then just indulge me for one more question, because this is something you guys should know for your exam. I already know some of you guys are going to get got, so make sure you're reading the question. When we start doing like the immuno sessions at the end of the year, the immuno sessions are just like, the questions are like absolutely absurd at first. And it's just like, like, I just love seeing people's thought processes in the chat. They're like, it's this one. Wait, no, it can't be this one. It's got to be this one. And they're like, I have no, and I'm like, yeah, I feel it. I feel it. This is how I am. This is exactly how I am. All right, so it's late. Let's go through this one. So the reason I said don't get got, so this one, the trick with this one is they wanted you to be between D and E, okay? Which a lot of you guys were. But with this one, usually with a question like this, they'll ask like, oh, which enzyme is affected? And in that instance, it would be E, but this one is D because it asks the patient's condition is most likely due to increased activity. But that's why I said don't get got, because it's like like a lot of the times when they ask about cataracts after like having diabetes, it's because like, oh, this enzyme is basically not working. Like sorbitol dehydrogenase is not working. So people are like, oh, they just automatically pick it. But this one was tricky. It was a tricky question. They're like, oh no, which one's increased activity? And it's aldose reductase. So we're going to go into, so here's like the first aid slide of it. So yeah, so these are so in terms of like a question like this, when they're asking about like, your eye issues because of, so cataracts because of glucose, because of diabetes, the two enzymes you should be thinking of are aldose reductase and sorbitol dehydrogenase. So a lot of you guys are like, oh, it can't be this one because this is like, not present in these instances. 100% correct. They really wanted you to be between D and E with this one. So in this, the reason I said I really wanted to go over this, like as the last thing we do today, is because you should definitely know what these Lurks organs are. So the Lurks organs are, the only organs that are going to contain aldose reductase. So that's your retina, the kidneys, and your Schwann cells. Your Schwann cells, these are your nerve cells. So a lot of the times when they say, like, oh, people with diabetes have peripheral neuropathy, it's because the Schwann cells get affected by glucose. Kidneys, you'll learn about this second year of renal, like all about the diabetic nephropathy that occurs with diabetes. You might even go into it a little bit with endo, but it's because kidneys have aldose reductase. And then lastly, this is kind of what the question was about, cataracts, is because retina, like in your eyes, have aldose reductase. And these are the only organs that have, oh, and the lens, sorry, just in the eyes. So this is basically why when you have diabetes symptoms, these are going to be the organs that are most affected, okay? So what aldose reductase does is it takes glucose, but let's say we have tons and tons and tons of glucose because we have, we have, whatchamacallit, we have diabetes. So aldose reductase is working on overtime. It's working, and it increases levels of sorbitol. And when sorbitol gets increased, this is what, sorbitol is very osmotically active, very. So if it's kind of like just somewhere, it's going to draw in water, and that's when you're going to get cataracts. That's when you're going to get all these other diseases and whatnot, okay? However, these Lurks organs don't have sorbitol dehydrogenase. They don't have it. So if they only have aldose reductase, if there's increased glucose around in these organs for a long period of time, you're going to get sorbitol accumulation, and then you're going to get osmotic damage in these organs. So a lot of the times when they ask a question like this, it's like, oh, why do patients have cataracts? And it's like, oh, because there's no sorbitol dehydrogenase, so you can't break down sorbitol. This question was asking, well, what enzyme is increased because there's, glucose around, and it's aldose reductase. So just don't get got with questions like this. They do like to go back and forth between aldose reductase and sorbitol dehydrogenase. And then here's the picture from Amboss showing kind of this exact same thing. So we have glucose, and then it's going to be your Lurks organs, lens and retina, kidney, Schwann cells. Sorbitol accumulates only within the cells that have aldose reductase without sorbitol dehydrogenase, which is these guys, and that's when you get that osmotic damage because it just pulls in all this sorbitol. In the other organs in the body, it's fine because there's sorbitol dehydrogenase. It just breaks it down into fructose, and then it can kind of go into those other hyperglycemic pathways. Okay, so just read the question and kind of see what they're asking, because again, we go back, the increased activity to which of the following enzymes, not, decreased or no activity, because we're in one of those Lurks organs, because they're talking about the eyes here. Okay? I just never want you guys to get got. All right, that's all I have. Going to stop.